Have you ever wondered how we can actually see inside our own digestive system without making a single incision? How we catch things like ulcers, tumors, or swallowed chicken bones all in real time? Welcome to the world of GI contrast procedures, where barium becomes your best diagnostic friend and fluoroscopy turns anatomy into motion pictures. In this episode, we're diving deep into the real-life techniques behind esophograms, upper GI procedures, small bowel follow-throughs, and barium enemas. We'll cover positioning, patient prep, image production, and we're bringing case studies into the mix. Whether you're preparing for your ARRT CQR or brushing up for the clinic, you're in the right place. Let's break it all down, one procedure at a time. Section 1. What are GI contrast procedures? GI contrast procedures help us visualize the structure and function of the digestive tract, from the mouth all the way down to the rectum. We use contrast media to coat or fill the inside of the GI organs, making them pop against the background on X-ray or fluoroscopy. What makes these procedures unique is how dynamic they are. We're not just snapping pictures, we're watching swallowing happen. We're following contrast as it winds through loops of bowel, and we're capturing abnormalities as they shift, reflux, or get stuck. These procedures are workhorses in diagnosing conditions like dysphagia, hiatal hernias, ulcers, obstructions, polyps, and even cancer. And because we're using fluoroscopy, technologists need to be on their A game with positioning technique and radiation safety. Here's what we'll cover today: swallowing dysfunction procedures, esophograms, upper GI procedures, small bowel procedures, and barium enemas. Each will include clinical scenarios, positioning tips, and image production strategies you can use tomorrow. Ready? Let's roll. Section 2. Equipment and setup. All right, let's talk tech. Before we even touch contrast, positioning, or the patient, we need to set up our battlefield. In GI contrast procedures, we work primarily in a fluoroscopy suite. This includes a tilting radiographic table, often with foot support or a compression paddle, a fluoroscopy tower equipped with either an image intensifier or a flat panel detector, a digital acquisition system for stills and cine loops, and of course, the operating console, the control center, where you select the fluoroscopy pulse rate, activate last image hold, and document dose. For barium enema procedures, your equipment tray might also include an enema bagger tip, retention cuff inflation bulb, water-based lubricant, contrast media, this may be single or double contrast barium, protective gear like lead gloves, aprons, and sometimes even a spot compression paddle. And don't forget image receptors or flat panels in case of overhead films. Do we use AEC and fluoro? Yep. Your fluoro tower uses automatic brightness control, or ABC. This is a dynamic version of AEC. It adjusts your KVP and your MA in real time to keep image density consistent, even as contrast fills or the patient shifts. Having the right gear and knowing exactly why you're using it keeps procedures efficient, safe, and diagnostically useful. This section touches everything from equipment operation to quality assurance and imaging informatics. Section 3. Types of contrast in pharmacology. Time to talk about the real stars of the show: contrast media. These magical liquids turn the invisible into the visible. And if you're working in GI procedures, you better know your barium from your iodine and when not to use either. Barium sulfate. This is your go-to for most GI contrast procedures. It's dense, coats mucosal surfaces beautifully, and gives that crisp white outline we love. But heads up, it's not water-soluble, and it's not safe if there's a suspected perforation risk of aspiration. Next up is water-soluble iodinated contrast, like gastric. This one's safer for high-risk situations like post-surgical patients, suspected perforation, or aspiration-prone patients. It's hyperosmolar, which can lead to diarrhea or dehydration if used in large quantities, especially in kids, frail adults, or elderly patients with limited fluid reserves. It doesn't coat the mucosa as well, so sometimes it's followed by a barium later for better detail. All right, let's look at ionic versus non-ionic iodinated contrasts. Come into two varieties. Your ionic puts you at a higher risk of reaction. Your non-ionic is safer, but it is more expensive. For GI procedures, water-soluble agents tend to be ionic, but always check your site's protocol before you push anything. Recognizing and responding to contrast reactions. Even though most GI procedures use contrast that stays in the GI tract, aspiration or absorption through ulcers or inflammation can trigger a reaction, especially with iodinated agents. Reactions are categorized into mild, which could include hives, warmth, or a metallic taste; moderate, which could include wheezing, vomiting, or tachycardia; and then severe, which could look like hypotension, bronchospasms, anaphylaxis. If any reaction occurs, stop the procedure, call for help, and monitor vitals. Administer oxygen or epinephrine per protocol. And remember, you must document the contrast name, volume, lot number, expiration date, and whether a reaction occurred. Pediatric considerations. Children aren't just tiny adults. Their fluid balance, GI motility, and reaction risks are different. When using hyperosmolar contrast like gastrographin in kids, always follow weight-based dosing. Ensure good hydration before and after, and never use undiluted gastrographin in neonates. Dosing and delivery. Recap. Dosage varies by procedure and patient. Swallowing dysfunction exams use different consistencies, from thin liquids to thick barium paste. Small bowel procedures often require repeat cup doses every 15 to 30 minutes until contrast reaches the cecum. Pop quiz break. Which of the following is true about barium sulfate? It's absorbed by the body. It's contraindicated in suspected perforation. It enhances iodine uptake in the thyroid. Or it's water soluble. The answer is barium should not be used if there's a chance of GI perforation. It can cause peritonitis if it leaks into the abdominal cavity. Next up, a patient starts coughing and turning red after swallowing gastrographin. What's your first action? Do you hand them water? Do you adjust the table angle? Do you stop the procedure and call for help? Or do you keep recording the exam? The answer is you stop the procedure immediately and call for help. Always treat suspected contrast reactions as emergencies until ruled out. Understanding your contrast options isn't just about making great images. It's about keeping your patients safe, managing risks, and making decisions that impact real lives. And from the ARRT's perspective, this hits pharmacology, contrast reactions, dose safety, pediatric considerations, and emergency protocols. Section 4, Patient Prep and Care. Before we ever hit the exposure button, we need to prepare the person, not just the equipment. GI contrast procedures can be uncomfortable, unfamiliar, and for some, even embarrassing. That's why patient care and preparation are just as important as positioning and technique. Pre-procedure checklist. Verify orders and indications. Confirm the correct procedure with the referring physician's note. What are we looking for? Dysphagia, reflux, obstruction? You want to walk into the room knowing what question you're answering. Second up, allergies. Medical history and pregnancy screening. Ask about allergies, especially to iodine, shellfish, or latex. Note chronic conditions like diabetes, renal issues, or recent surgeries. And always ask females of childbearing age if they might be pregnant. Third up, NPO status and prep. Most procedures require the patient to be NPO for 8 hours, no food, drink, gum, or smoking. This reduces the risk of aspiration and improves image clarity. For barium enema procedures, prep might include bowel cleansing agent the night before. If they didn't do it, you'll know by the scout image. Fourth, we have consent and explanation. Always explain the procedure Always explain the procedure in clear and simple language. Describe how the contrast will taste or feel. Tell them about positioning changes, compression paddles, and potentially after effects like white stools. If contrast will be administered, informed consent must be obtained, either written or verbal, per facility policy. During the procedure, ensure modesty and comfort. Make sure the gown's tied correctly and blankets are available. Check for fall risks, especially during upright exams like a swallowing study. Encourage communication. Let them know they can speak up if they're in pain, nauseous, or anxious. Be ready to assist with vomiting, aspiration risk, or emotional distress, especially with pediatric or trauma patients. Post-procedure instructions. Hydration is key, especially if contrast media was hyperosmolar. Reinforce that white or pale stools are expected after the barium. Let them know to contact their physician if they experience pain, vomiting, or difficulty passing stool for more than 24 to 48 hours. If a reaction occurred, document it and provide follow-up instructions. Pop quiz break. Which of the following patients would require extra caution before a GI contrast procedure? A healthy 22-year-old athlete, a patient who skipped breakfast but drank water, a 70-year-old diabetic with recent abdominal surgery, or a teenager with seasonal allergies? The answer is a diabetic with recent abdominal surgery is at a higher risk for delayed gastric emptying reaction to contrast or complications during bowel prep. Always screen thoroughly. Patient prep is more than paperwork. It's about setting the stage for safety cooperation and diagnostic success. In this section, you just checked off patient care, vital screenings, legal consent, communication, and post-procedure care, all part of the ARRT CQR core. Section 5, Positioning and Projections. Swallowing dysfunction procedure. Let's kick it off with one of the most collaborative procedures in GI imaging, the swallowing dysfunction procedure, also known as a modified barium swallow. Unlike other GI procedures, this one is done with a speech-language pathologist right there at your side. You're not just observing anatomy, you're evaluating function in real time. The purpose of this is to assess the oral and pharyngeal phases of swallowing, identify the risk of aspiration, penetration, residue, or reflux, and determine if a patient can safely eat and what textures are safe. The projections in this procedure include a technique lateral view, which evaluates the bolus transit, airway protection, and aspiration. Your AP view assesses the symmetry, pooling, and bolus path midline. The procedure involves multiple consistencies: thin liquid, nectar thick, honey thick, pudding, and solid items like a cookie. Here's a positioning tip. Seat the patient at a 90-degree upright angle. Center the oral cavity and cervical esophagus. Keep the shoulders out of the way to avoid superimposition. Common findings include penetration. This is where barium enters the laryngeal vestibule, but not below the cords. Then we have aspiration, where barium enters below the vocal cords. We have residue, where barium remains in the valleculae or piriform sinuses after the swallow. And then we have a delayed swallow, which is poor timing of the pharyngeal elevation. Next up, we have a case study. Let's look at a high-risk case from Radiopedia. An elderly patient with a history of stroke presents for a swallowing assessment. During the lateral view, we see the liquid barium enter the trachea and descend below the vocal cords, a clear case of aspiration. This case highlights the importance of having emergency suction nearby, working closely with speech pathology, and recognizing silent aspiration, where no cough is triggered at all. Pop quiz break. Barium entering the airway below the vocal cord is called what? Reflux, penetration, residue, or aspiration? The answer is aspiration. It's dangerous, especially if it goes unnoticed. That's why lateral positioning and real-time observation are critical. Common errors and fixes. Poor contrast visualization. Use a fresh, properly mixed contrast in the correct viscosity. If you have obscured anatomy, adjust the table height and arm position to get the cervical spine out of the way. If you have a missed aspiration moment, record continuously through multiple swallows and pause playback to review frame by frame. Esophagram procedure. The esophagram or barium swallow is your go-to procedure for visualizing the structure and function of the esophagus. It's fast, informative, and can reveal subtle pathology if your positioning and technique are spot on. Clinical indications: dysphagia, difficulty swallowing, painful swallowing, foreign body, strictures, reflux, or ulcers, follow-up for cancer, motility disorders, or infections. Your standard projections include RAO, which best demonstrates the esophageal peristalsis and shifts the esophagus off the spine. Your left lateral view shows anterior and posterior wall separation and dynamic motion. Your AP, general overview, may show dilation or a mass effect, and your PA is useful for minimizing magnification, especially in larger patients. LAO alternates oblique view to enhance visibility or motility of masses. Positioning tip: RAO should be 35 to 40 degrees oblique, center at T5 to T6, with the top of the barium cup just below the chin in the profile. Here's the anatomy you must visualize: the cervical, thoracic, and abdominal portions of the esophagus, the aortic arch indentation, left atrium compression, gastroesophageal junction. Next up is a case study which shows us Candida esophagitis. A patient with advanced immunosuppression presents with odonophagia during the esophagram, specifically in the RAO view. Multiple irregular plaque-like filling defects are noticed along the esophageal mucosa. This is a textbook case of Candida esophagitis. RAO enhances the mucosal coating by moving the spine off the midline, allowing these subtle lesions to appear. Lateral and AP views help confirm the length and depth of involvement. Candida thrives in immunocompromised patients, those with HIV or AIDS or undergoing chemotherapy. Recognizing these signs early can prompt life-saving antifungal treatment. Pop quiz break. Why is RAO projection preferred over the AP view during an esophagram? It uses less radiation, it shortens the procedure, it shifts the esophagus off the spine, it eliminates the need for contrast. The answer is, it shifts the esophagus off the spine. This avoids overlap and helps demonstrate peristalsis and mucosal detail more clearly. Common errors and fixes. If you have poor mucosal coating, have the patient rotate the cup and take slow sips between breaths to ensure even distribution. If you have missed pathology due to superimposition, use multiple obliques and ensure proper RAO angle. If you have an insufficient exposure time, document motility over several swallows and include spot images of abnormal segments. The upper GI procedure examines the esophagus, stomach, and duodenum using fluoroscopy and contrast. It's dynamic, diagnostic, and extremely position sensitive. You're not just imaging, you're storytelling with barium. Primary indications: epigastric pain, primary indications include epigastric pain or nausea, a suspected peptic ulcer, hiatal hernia, mass, or reflux, post-op evaluation after maybe a gastric bypass, or to rule out gastric outlet obstruction or delayed emptying. You must capture the fundus clearly, the body, antrum, and pyloric canal of the stomach, the duodenal bulb and C-loop, the first and second parts, the gastric folds and the rugae, the gastroesophageal and gastroduodenal junctions. Standard projections include Scout KUB, that's your baseline image. We get this for prep or pathology. An RAO, this is your 40 to 70 degrees. It's best for your pylorus and duodenal bulb images. Your LPO, this fills the fundus with air for mucosal contrast. Your right lateral, this is excellent for retrogastric space and duodenal sweep. Your PA and AP images, this gives us the general outline and a comparison image. Tip: an RAO Keep the left arm up and the right arm down with a pillow under the hip for stability. For duodenal bulb clarity, ensure tight collimation and center at L1. Next up is a case study where we see a gastric polyp. This is a 55-year-old patient who complains of vague fullness and upper abdominal discomfort. During an upper GI procedure, a subtle filling defect is observed in the body of the stomach on the LPO. It's a gastric polyp. These benign lesions often go unnoticed without optimal mucosal coating and multiple views. RAO and LPO projections help outline the lesion by contrasting air and barium on different surfaces of the stomach. Polyps can be precursors to cancer. Radiologists flag them for endoscopy follow-up, so clear imaging literally saves lives. Pop quiz break. Which projection is best to visualize the duodenal bulb during an upper GI procedure? LPO, RAO, right lateral, or AP? The answer is RAO. This view opens up the duodenal bulb and canal by angling the patient forward and right, ideal for coding. This is ideal for coding and visual separation. Common errors and how to fix them. Folds not visualized. Try air contrast technique or use compression. Duodenal bulb obscured. Recheck your RAO angle and centering at L1. Is the patient struggling to swallow on cue? Practice dry runs before exposure and encourage slow, deliberate sip. Next up, small bowel procedure, often called a small bowel follow-through. This is the marathon of GI contrast procedures. It's slower, more detailed, and incredibly useful when timed and interpreted correctly. Purpose and indications are suspected small bowel obstruction, Crohn's disease, or malabsorption. Post-surgical follow-up, maybe for a bowel resection or anastomosis, or if somebody has abdominal pain with an unknown cause, or to evaluate transit time and motility patterns. The anatomy you're tracking is the duodenum, jejunum, and ileum. Follow contrast from the stomach through the loops. Watch for changes in caliber, mucosal markings, and the time to cecal filling. Begin with a PA scout to assess prep and gas patterns. Administer oral contrast, usually 2 to 3 cups of barium sulfate. Take PA images every 15 to 30 minutes. When contrast nears the terminal ileum, take spot images of the ileocecal valve area. Positioning tip. Keep images PA. This compresses loops and gives better bowel spread. Ask patients to walk or roll between images to help transit. Next up is a case study, small bowel obstruction. A patient presents with severe bloating, nausea, and no recent bowel movements. After barium is administered, the follow-through shows dilated proximal small bowel loops with prominent air fluid levels and a sharp transition to collapsed bowel. Textbook mechanical small bowel obstruction. This case illustrates the power of timing and persistence. The obstruction isn't visible in the first image. It unfolds with each 15-minute check. And most small bowel obstructions are caused by adhesions or hernias. The sooner you spot them, the faster the surgical team can intervene. Pop quiz break. How do you confirm that the small bowel procedure is complete? When the patient has no more symptoms, when contrast reaches the hepatic flexure, when contrast reaches the cecum, or after 45 minutes? The answer is when the contrast reaches the cecum. That's your landmark. No cecum, no completion. Common errors and fixes. Missed obstruction. Don't rely on early images. Track it over time. Contrast layering poorly. Instruct the patient to sip steadily and stay upright. Image overlap. Have the patient change position or walk between films to separate loops. Barium Enema procedure. The Barium Enema procedure may not be glamorous, but it's essential. It gives us a full survey of the large intestine, highlighting mucosal detail, shape, contour, and even early signs of disease. And yes, we still do them, especially when colonoscopy isn't tolerated or there's a post-surgical question. Why do we do it? Chronic constipation, diarrhea, or lower GI bleeding, colorectal cancer screenings when colonoscopy fails, pre-surgical mapping or post-op follow-up, Evaluate diverticulitis strictures or obstructions. The anatomy you must see: the rectum, sigmoid, descending, transverse, and ascending colon. Hepatic and splenic flexures, cecum and appendix, if visible. Required projections: start with a scout KUB, then use PA or AP. LPO and RPO obliques, visualize opposite flexures. Left and right lateral decubitus, air contrast separation. Your left lateral demonstrates the rectum. Your AP axial or PA axial highlights the sigmoid. The post-evacuation view assesses clearance. Positioning tip: for decubes, use double contrast technique and tight collimation. For the axial sigmoid views, angle the tube 30 to 40 degrees cephalad, AP or caudad, PA, to open up the rectosigmoid region. Next up, colonic diverticulosis. An elderly patient presents with cramping and irregular bowel movements. The enema shows multiple round contrast-filled outpouchings along the sigmoid and descending colon. Classic diverticulosis. This case proves how effective the enema is at showing surface-level abnormalities that might go missed on CT. In diverticulosis is common in older adults and often asymptomatic, but inflamed, it becomes diverticulitis, which can mimic other GI emergencies. Pop quiz break. What projection best demonstrates the rectosigmoid region during a barium enema? Right lateral, RPO, AP axial, or left lateral decubitus? The answer is AP axial. The cephalic angle helps open the sigmoid loop and prevents overlap. Common errors and fixes: overfilled colon, drain slightly before post-evacuation images. No air contrast separation, adjust table tilt and the volume of the air. Uncoated diverticula, gently roll the patient and reinstill contrast. Gently roll the patient and reinstill contrast to fill the outpouchings. LPO and RPO show the splenic and here's a tip. LPO and RPO show the splenic and hepatic flexures respectively. Flip those in your mental file folder. Section 6, image production deep dive. Okay, you've got your patient positioned, your contrast is flowing, and your projections lined up. Now it's time to actually create the image, the part where physics, fluoroscopy, and digital processing collides. This is where good radiologic technique becomes great imaging. In fluoroscopy, what's really happening? GI contrast procedures use continuous or pulsed fluoroscopy to capture motion. Think of it like a live video for anatomy. Your automatic brightness control ABC is adjusting the exposure dynamically as contrast moves in and out of the field. Unlike static imaging, this means you need to think in real time, adjusting collimation, table height, and patient position as the exam unfolds. Here's a tip. Use pulse fluoro, low frame rate to reduce dose and improve visibility of motion without overexposing. Image acquisition. Essential KVP settings. For barium, use a high KVP. This is typically around 110 to 120 for optimal penetration and coding detail. Iodinated contrast. Drop to 90 to 100 kVp for better subject contrast. Mass or pulse width is adjusted by ABC and fluoro, but in spot images or overheads, you control it. Use AEC when possible for consistency. Your SID and OID. Keep your SID around 100 centimeters and minimize your OID to reduce magnification and distortion. Image processing. GI fluoro is stored digitally as spot image, video loops, overhead projections like scout or post-evac. These go through a histogram analysis to normalize brightness, then a lookup table or contrast and tone mapping. It sets a window width and level for post-processing clarity. Think of histogram analysis like a brightness filter. The system adjusts your image based on expected anatomy. Garbage in, garbage out. Pop quiz break. What does increasing KVP due to contrast in a barium in a barium GI procedure? Increases image contrast, decreases image contrast, has no effect, or makes the table vibrate? The answer is B, it decreases contrast. But that's okay. High kVp is used intentionally to get through dense contrast and still see anatomy. Common image production pitfalls. An underexposed image could be incorrect AEC, selection, or poor collimation. Reposition, adjust centering, and check that the chamber is under the anatomy of interest. Washed out images on digital display. Adjust your window width and level before assuming it's a technique issue. Air bubbles or contrast streaks. Happens with poor prep, old contrast, or inadequate mixing. Watch your prep procedures. The golden rule: you can't fix what wasn't captured, but you can always improve a good image in post. All right, let's talk about something you don't want to leave glowing: your patient, yourself, or your career. GI contrast procedures often involve fluoroscopy, which can rack up exposure faster than you can think. This section is all about how to do your job safely, responsibly, and legally. Protecting the patient. Use pulsed fluoroscopy instead of continuous. Take advantage of last image hold to avoid repeat exposure. Keep the beam on time to a minimum. Use tight collimation. Radiation that misses anatomy is pure waste. Adjust table height and SID to reduce dose without sacrificing image quality. Here's a bonus tip. Ask the radiologist to narrate findings while viewing the LIH instead of fluoroing nonstop. Protecting the tech, that's you. Always wear a lead apron and thyroid shield. Use lead gloves during manual positioning. Stay behind the control barrier whenever possible. Stand on the image intensifier side. The beam exits on the opposite side where scatter is strongest. Fluoro dose documentation. ARRT expects you to know how to record fluoroscopy time. Dose area product, your DAP, that's your total radiation delivered. Any repeat exposures and why they occurred. If you didn't write it down, it didn't happen, and it could come back to bite you during an audit. Daily Q&A for GI procedure check. Check fluoro unit warm-up and calibration. Verify the ABC system, your automatic brightness control, is functioning. Confirm correct SID, grid usage, and image receptor setup. Ensure emergency equipment like suction and oxygen is available and operational. Pop quiz break. Where should you stand to reduce scatter exposure during a fluoro procedure? On the tube side, in front of the control panel, behind the radiologist, on the image intensifier side? The answer is the image intensifier side. Scatter is worse on the exit side of the beam, so hug that image intensifier like it owes you money. Common mistakes and how to fix them. Skipping the collimator. The wider the fields, the more the dose. Tighten it up. Lead apron gaps. Tuck, adjust, and double check for overlaps. Fluoro timer alarms ignored. These are legally required for a reason. They help prevent overexposure and hold you accountable. All right, here's my final thought. Protecting your patient is important, but protecting yourself is non-negotiable. Burnout won't get you, but scatter might. You made it through projections, contrast, radiation safety. Now it's time to look at what you actually produced, the image, the diagnostic result, the proof. ARRT wants you to know not just that you took the picture, but that you know how to critique it. What are we evaluating? Every GI contrast image, from fluoroscopic stills to post-evac overheads, should be checked for anatomy inclusion. Did you capture what you were supposed to? Contrast distribution. Is the barium or iodine where it needs to be? Exposure quality. Is it over or underexposed, grainy or washed out? Motion. Voluntary or involuntary blur? Labeling. Side marker, decubitus labels, timestamps, scout versus spot versus post-evac, clearly marked. Think like a radiologist for a minute. If they can't see the anatomy clearly, they're making educated guesses. That's not good medicine. Evaluation tips by procedures. Swallowing dysfunction. Watch for penetration, aspiration, and the symmetry of the bolus flow in the AP view. In the esophagram, look for mucosal coating and smooth contour. Overlapping spine in AP and PA means a redo. In the upper GI, assess for rugal folds, duodenal bulb filling, and clear air fluid levels. In the small bowel, is the contrast progressing on time? Did you catch the cecum? Are loops overlapping? In the barium enema, is the entire colon visualized? Did you use sufficient air contrast separation? Did you capture all required projections? Pop quiz break. You notice the sigmoid colon overlaps itself on the AP axial image. What's likely wrong? You didn't roll the patient, you used the wrong SID, you forgot the tube angle, you used too much contrast. The answer is you forgot the tube angle. Without proper angulation, 30 to 40 degrees cephalad or caudad, the sigmoid folds back on itself, making interpretation impossible. Common mistakes: image review missing the cecum, no completion credit for small bowel studies if the endpoint isn't visible, motion blur in the decubitus, wait for the patient to settle fully after repositioning, no side marker. You'd be surprised how many retakes happen because someone forgot tiny r or l. Okay, deep breath. You just made it through one of the most detailed, projection-heavy, contrast-stripping procedures in all of radiography. You didn't just learn what to do, you learned why it matters. From choosing the right contrast, to timing the perfect small bowel image, to catching a gastric polyp before it becomes a bigger problem, to knowing when a case of aspiration could send a patient into respiratory distress. You now know how GI contrast procedures connect positioning, image production, pathology, patient care, and safety to one continuous workflow. You're not just taking pictures, you're telling diagnostic stories. And this chapter, you just nailed it. If this helped you feel more confident heading into your ARRT CQR, rotations, or next class, let me know. Drop a comment, share your favorite case from this episode, or better yet, tell me what you want to see next. And hey, shout out to Soulful Maple for requesting this in the first place. You helped guide this episode. Coming up next in Abdomen Part 3, we're going full hands-on with pediatric adaptations, contrast tips for kids, and trauma protocol in the acute care setting. That means poop bags, patient restraints, reflux, surprises, and more caffeine than you should legally consume. You don't want to miss this. Thanks for watching. Keep learning, keep laughing, and keep showing up like the rockstar rad tech that you are.